Everyone in Zoom, can you hear us okay? If you guys can write in chat or give me a reaction.
Yes, we can.
Perfect. Thank you, Alicia.
Okay, and then
This is so awkward. I've never done this.
well, yeah, I mean, I'll say something about how I don't think we've ever had a hybrid.
No, ever.
And when we're voting, I'll ask them to vote in the chat.
Yeah.
And if we're still at quorum,
And then you just want to, for like, I guess like housekeeping, remind them that anyone who's giving like feedback or like we're asking a question
need
in
to
the
do it
room,
in the
they
mic.
need to do it in the mic.
so when people are in motion, I need to raise your hand. Okay. Are we at quorum still? Okay. Hi, everybody. Welcome to our first hybrid meeting. So we've got some folks online as well. We are at quorum. So I'm going to call this hybrid meeting to order at 3:02. Just some housekeeping because we are in hybrid. We can't see them, but Melissa's got folks on the screen. And they should be able to hear me. So if they've got questions or want to add, I think they can raise their hand or write in the chat and Melissa will stop me. And we'll make sure that gets shared with the room. When we're doing motions and things, you need to speak into the mic. So if you don't mind raising your hand, I'll run it over to you and have you say that in the mic. So we've got it recorded so that folks can hear it as well. And for the notes later. Are there other things that I'm missing with hybrid? Okay. And normally we type into the chat when we vote. We only have one item today to vote on, which is the notes. So instead of, if you're in the room, we'll be doing that vocally with the yes, yay, nay. And then for folks that are on Zoom, we'll be doing that in the chat and Melissa will help us keep track of that. All right. Thankfully, it's not too complicated. So we'll keep it moving. We've got public comment period. Is there anyone signed up for a public comment? Okay. Anyone in the room today that didn't get a chance that's interested in public comment online? All right, hearing none. So then we'll move on to the approval of minutes. This is a voting item, so we can practice our hybrid voting. Members should have received those January minutes via email from Russ, our secretary, on Monday evening. Do we have any edits or corrections? Were there a copy of those minutes in our folder today? So they are? No. Okay. It's probably the agenda. So if you have your computer, you can pull that up, or if you've already had a chance to look at it. Any edits or corrections? Okay, so I'll open the floor for a motion to approve the minutes for our January 2024 HSAC meeting.
Hi, Helen Tripp, make a motion to approve the minute.
Thanks, Helen.
And I'll second it, Renee Vaughn.
Thanks, Renee. All right, so we have a motion and a second. All in favor, please indicate so by saying yay. Yay, and all those against, nay. All right, and if you're online, please vote in the chat. Yes, no, or abstain. Great. Our minutes are approved for January. Wonderful. Congratulations, our first hybrid vote, I believe. Moving right along, we have an executive committee quarterly report. That's from our executive team, and I'll share that with you very briefly. What we did this morning, the retreat that we just accomplished was a big piece of what we've been working on and talking through. We've also been reviewing the governance charter and policies and receiving attendance updates. So as we've shared, those attendance policies are important, and there are reports that get sent to the clerks. And so we talk about that at exec as well. In December, Colin and I gave an HSAC update to the county commissioners and city council as a part of a joint meeting. And then you all were involved in the budget request following that presentation that we approved together, and that was sent to the elected bodies in early February. So that was some of the things we accomplished. Moving right along. Next on our agenda is the HSAC retreat summary, and that will be information only, and Melissa will share that update with us for those that were not able to attend. No? I just did that. There's a lot of things happening.
All right, so let me just share my screen. Give me 2 seconds. All right, can everyone online see the agenda that's on screen for the retreat? If you'll just write in chat yes or no. All right, perfect. So we just wrapped up with our HSAC retreat. We started with, some time to make introductions because as many of you know, after COVID, a lot of us just went completely virtual for most of our meetings. So there are a lot of HSAC members who didn't even get to meet each other yet. So this was a nice time for a lot of people to meet each other and get to speak to each other outside of their HSAC meetings, some for the very first time. We did have a HSAC year in review. So we went over approved agenda items for since August of 2023 to present. So we went over all of those approved items in the very first session of the day. And then we also just went over like some additional background in terms of the different standing committees, their function within the HSAC, and what is it that an HSAC can do? Like, what does a Homeless Services Advisory Committee do as a policy body, and what are the limitations? So we did go over that in the very first session of the day. We also took a tour of UMD shelter space. Again, like with everything being virtual, sometimes we forget some of the spaces that we're actually working in. We talk a lot about shelter spaces, rapid rehousing, and all of those things. And this year, especially, the HSAC has had a lot of conversations around emergency shelter and access to shelter in general. So we thought it was really important for some of our HSAC members who have not gotten a chance to actually see a shelter space since COVID to actually tour the space and see what UMD is currently using as their shelter. We also had a community resources update, and we had one of our very own HSAC members, Abna Bediako, give a brief overview of HEART and the work that HEART is doing. HEART has been doing a lot within our community. They even, stood up emergency shelter, no turnaway shelter for the very first time during one of our most recent white flag, low temp days. So, we are wanting to work more with our community partners. So we spent some time talking about some community initiatives that are currently in place, and that we're hoping will expand community partnerships throughout, not just with HEART, but with law enforcement, with health and safety, so with other departments across Durham, and how can we better utilize our services within Durham. One of our staff members, Lloyd, also went over COC funded projects. He went over all of the different funding sources that currently fund our homeless system and that are approved through the HSAC, and then some funding decisions that are completely out of our control, like dedicated housing fund and those sort of things that we still see filter into the homeless system and that currently fund a lot of the programs that we currently have. He also went over an overview of the different types of programs within our homeless system, including rapid rehousing, permanent supportive housing, emergency shelter, transitional housing, and street outreach, some of those which are not necessarily funded through the homeless services or through the COC. Then finally, the last thing we did, which was probably one of my favorite things, is that we did a small group discussion, and there were a series of 8 questions that we had our membership split into groups for, and talk about. Now, I did want to share these questions with the full group, so let me go ahead and get that up here. And the reason why I will show you these questions is because the ultimate goal is that we're hoping that we'll have some future action items that will come out of these questions. There it is.
Excuse me, while Melissa is bringing up these questions, let me offer a clarification. In my presentation earlier this afternoon, I did not talk about transitional housing. Transitional housing is currently a very small intervention that is being used in Durham. Currently, only TROSA, Triangle Residential Options for Substance Abusers, has transitional housing that is dedicated for use by veterans who have experienced homelessness and are participating in the therapeutic community at TROSA. Their program is a maximum of 2 years, and transitional housing programs had been an intervention to help address homelessness, but it has fallen out of favor, particularly with our federal partners at HUD because of the expense largely. It's not a very efficient use of public dollars, although there are still some transitional housing programs, obviously, that are in operation. But in Durham, we only have those 20 beds. Volunteers of America had a contract with the VA to provide transitional housing for veterans at Maple Court, but they transitioned away from that use to also use those beds now as permanent supportive housing. So we just have the 20 beds left. Thanks.
Thank you, Lloyd. So for the questions that our HSAC members worked on during the small group discussion, I will also say we were very fortunate that Anthony actually asked some of our lead work group team members to come and join this discussion as well. So it was really nice to have some persons with lived experience. We made sure that there was at least one person with lived experience in every single group, so that while we were having discussions, we're also thinking about those who have actually experienced homelessness and their thoughts and ideas in terms of answering a lot of these questions. So for the first question, in your opinion, is the Homeless Services Advisory Committee effectively achieving its goals? Why or why not? The second question, how can we better engage with the unhoused community to understand their needs and preferences? The third question, what are the key challenges or gaps in our current approach to addressing homelessness, and how can we overcome them? The fourth question, are there specific populations within the homeless community that are underserved or face unique barriers? And how can we tailor our work to better meet their needs? Question number 5, how can we improve coordination and collaboration among various stakeholders involved in the HSAC, including government agencies, nonprofits, and community organizations? Number 6, what strategies can we implement to increase public awareness and support for the work of the HSAC? Number 7, are there innovative approaches or best practices from the communities that we could adopt or adapt to improve our work? And the final question, how can we measure the effectiveness of our efforts and continuously monitor progress towards our goals? Now, the purpose of these questions specifically is that they're geared towards giving our HSAC an opportunity to evaluate the goals that we have set. We've already discussed HSAC goals in the past when we did our discussion, our Jamboard discussion. And this was a way of trying to see how can we look beyond that even further and see if there are other unique ways in which the HSAC could better serve our homeless community. The other thing is that a lot of these questions, I will be honest with you, are stolen from these HSAC meetings. Some of these questions have been asked during our HSAC meetings. And I think that our chair has spoken about this and some of our staff members as well. We're trying to be a little bit more intentional about some of the discussions that we have in HSAC and some of those questions that are posed to the HSAC. How can we turn those into action items moving forward? So I didn't give you any of the answers that were shared during the retreat today, but the plan is that we'll compile the answers that we got during the retreat, turn it into data that we can share with the full HSAC, and hopefully some action items will come out of that to better help the HSAC be an HSAC and do more within the community, but also so that we can better our system in general if there are things that HSAC has the power to do to help things be a little bit more efficient. I think that's everything.
Thanks so much, Melissa. And I will just have to give Melissa another shout out. She did so much work in putting this together and has done an incredible job. So let's please give her a round of applause. Those folks at home too. Thank you again, Melissa, so much. Next on our agenda is a presentation that Sharita is going to do for us. This morning on our tour, we got to, and Julia. Hi, Julia. And Julia. This morning we got to go and see, walk through the clinic that Sharita often talks about. And so we thought it would be helpful to follow up with some more information so that we can learn as we also got to see.
Good evening, everybody. Again, my name is Sharita McCullers. I'm the social worker at the Lincoln Community Health Center, Healthcare for the Homeless Clinic. Next slide. So for healthcare for the homeless, our definition is broader than our COC definition for homelessness. So for healthcare for the homeless, a person who lacks a permanent resident who resides on the streets, in a shelter, in missions, single occupancy, rooming houses. Basically, essentially, next slide, if the person doesn't have a lease, they are eligible to be a patient in our clinic. Next slide. And next slide. So these are the places they come from. This is where we're located. So we actually our door shares the porch at Urban Ministries. So there's one door you enter for the shelter, and the other door on that porch is the Healthcare for the Homeless Clinic. Our address is 412 Liberty Street. We're open Monday through Friday from 1 o'clock to 5 p.m. And on the first and third Wednesdays, we actually have a psychiatry clinic where we have residents from Duke that come in and see patients who need more intense psychiatric kind of medication management needs. Next slide. Next slide. So these are just a list of the services, and the services change. And the reason why I say the services change is because basically my role as a social worker case manager, LCSW, is pretty much to meet any need or any challenge that a person walks in the door with. And so these are just a few of the things I do. So of course I do advocacy, not just one-on-one for folks, but I also do things like the HSAC and talk about bigger overarching issues to try to inform the system to help our patient population. I help people with housing. I do provide supportive services for folks. So folks that I house, 9 times out of 10, if there's a problem, their landlord calls me and I go. I also do disability assistance. So I am a SOAR worker, but I do varying degrees of disability support. So I do the SOAR process, but some people just need a little light touch. They need help with forms and things like that, where I don't have to do the intensive SOAR work. So I also provide that service to our patients in the clinic. I do navigation outreach. I get on buses with people. I try to ride the bus. I go to appointments with them. Years ago, there was a Familiar Faces. I call it probably 1.0, and the Heart team is doing that, the new Familiar Faces initiative. We were doing a lot of work specifically around emergency room diversion. We actually, there was a grant through the National Healthcare for the Homeless Council that actually gave us 3 years of a community health worker who was specifically dedicated to working with high utilizers of ED to get them to connect to primary care in our clinic. And the data was phenomenal. It really, really worked. And so we try to continue that. We don't have an embedded community health worker, but if I need to do outreach, I am available to do outreach as well. Right now, so starting on February 19th, we just embedded a DSS social worker over in our clinic on Mondays and Thursdays, and she will be there doing Medicaid applications because, as you know, Medicaid expansion has happened, and so a lot of our patients qualify. And so although I do help people do Medicaid applications, we thought it would be nice to have somebody who could directly link into the system and get applications in a more rapid way. Next slide. Okay, so as I shared this morning with the people on the tour, our copay is $1 for our clinic, but if a person doesn't have the $1, they're able to be seen. Another huge benefit of being a patient in our clinic is that if our folks need medications, there's not a barrier to access. So as long as if the person has essential medication needs, and as long as they're a patient in our clinic, they can access their medications at Lincoln and be billed for them. So they do not have to pay if they don't have the means to pay, but they will secure their medications. So for a lot of our folks, that is huge. The only caveat is that it has to be a medication that Lincoln carries in Lincoln's pharmacy. So sometimes there are some medications like, for example, your injectable psychiatric medications, we don't have the ability to prescribe those from Lincoln Pharmacy for folks to get. If a person does have insurance, our providers are able to prescribe at Gurley's and things like that, but the person has to be able to afford to get that, secure that medication. And then I think another thing about our clinic is that one of our providers, our main 3-day-a-week provider, is an MD and a psychiatrist. So it gives us the ability to provide psychiatric real-time response for people to prevent, mental health crisis or lapses in needed medications, preventing that from happening and helping people in real time. Some of the challenges that we still have is that there is a copay for dental, and if folks go to our behavioral health department at Lincoln, the copay is a different requirement that we cannot waive. So that's just a few of the challenges I'd like to highlight. The asterisk is there because Medicaid expansion, we're still learning what Medicaid expansion is doing to the safeguards we put in place to help folks. And so as soon as Medicaid expansion happened, we had to go back to the pharmacy and say, hey, Medicaid has a $3 copay for some meds, $4 copays. And so we had to readjust. And so as we are becoming more familiar with what it feels like for our folks to have that insurance, we're adjusting and tweaking our systems. So I just wanted to highlight that. Next slide. So we are a full service primary care clinic. Now, when the clinic started, it wasn't. It was a night clinic, and they did mostly foot care stuff. And that was around 1998. And at some point, and Julia probably knows that year, there was a transition from us just doing urgent care to primary care. And so that's important because a person can get all of their needs, whole person care at our clinic. And that is how we're different. We are an integrated care model. When the patient shows up at the door to see the doctor, they see the social worker too. If they have a substance abuse diagnosis, they see the substance abuse counselor. So they are informed very quickly of the additional added supports that are available to them as patients in our clinic. Because we are a full service primary care clinic, we do operate on an appointment. So we do have patients that are scheduled, but we take walk-ins every day, Monday through Friday. The only thing we ask is that if you are going to walk in, for you to be there at 1 o'clock when we open the door, because we're limited. So we allow 2 slots for walk-ins automatically. But as people don't show up, so we have no shows, we can actually fill in more slots. So there's a potential that instead of us seeing 2, we can see 4 or sometimes 6 people in that one day new getting to care. And if they're coming early enough and we're getting them in, they can probably even get their medication at Lincoln the same day. Next slide. So I just wanted to share this slide just to give you an idea of the number of visits. I can't read it. I can't read it from here. I think in 2023, there were around 1,300 medical visits and about 1,200 social work visits, with probably about 70% of those being mine. stayed around the same 2022, and the last two are just kind of year to date where we are since the beginning of the year. So we're at what, 300, almost 300 visits, almost 175 social work visits. So I just said it to say that we are seeing people, we're meeting their needs. I wanted to have the 2023 numbers for you about how many unique patients we had, but that data is not yet available to us under the UDS where we report our numbers annually. But in 2022, we had 441 unique patients. We have more people that we can serve. And so the reason why this slide is here is to say that, yes, we're here, we're working, you can see it in the numbers, but there is so much more that we could do. That might be able to open up more hours, us opening up in the morning, some days of the week and things like that. But more than anything, we are here to serve. We exist to serve this population. So we want to see the folks that are being served by our homeless service providers. If they do not have primary care, if they're telling you they feel like they have a disabling condition, primary care is like paramount to successfully navigating a disability process. And so as soon as you're having those conversations with those people that you're serving, if they don't have a primary medical care home, we are here. We are here. There's also another clinic in the community that Julia might bring up in her part of the conversation that's also available, but I just want you to know we're here, we're ready to serve, bring folks to the door as walk-ins. I'm there at 8 o'clock in the morning. If you want to call, if the person's already registered, just having a hard time getting in, I can get them on a schedule. So just know that we're here and ready to do work. Next slide. So how are we funded? So Lloyd shared that last bullet. So fiscal year 2023, our program was about 426,000 roughly, and 57% of that, those funds were from public dollars. But we also have other, we get federal money from the federal government. Lincoln does have a foundation, so money is coming in, however they're dispersing that among programs, other grants, and then we do get in-kind donations. So our 3-day-a-week MD psychiatrist is actually an in-kind donation from Duke to our clinic for those 3 days. So that's just like an example of in-kind donations from Duke. Our access to Epic is actually gifted to Lincoln from Duke as well. So, those contributions make a huge difference. So when our patients are showing up to the emergency room, or they're showing up to the ED, they're, getting admitted, we can see what's happening in real time. Sometimes if we need to intervene or help plan out discharge plans, we can do those things in real time. Next slide. So this is a slide just giving you a little bit of history about Lincoln. So Lincoln turned 50 in 2021. We have 11 clinics across Durham. Our newest clinic just opened last year in Lakewood Shopping Center. Has anybody been over to see it? So that's our newest clinic. But I think the other important thing to let you know is that we do have 2 partnership clinics, one at Lions Park and one at Holton. They are Lincoln clinics, but they're staffed by Duke providers. And we also have a clinic in our local crisis center as well that serves folks who come in who need medical needs beyond the services that DCRC provides. Let's see. Julia, this is your slide. So we also have a HIV early intervention clinic that is located at our health department. And in that health department clinic, we also have our PCC clinic, which just provides primary care to individuals in the community who want to access a Lincoln clinic, not at Lincoln on Fayetteville Street. Just another option. Next slide. So that is all for my part, and I'm going to turn it over to the illustrious Julia Gamble.
Thank you. Microphone is different to me, so let me know if I'm sounding weird to y'all. I just thought it might be worth talking about primary care and why, and Sharita did a little bit of that, but I think it's important to just understand that the idea is that everybody should have a primary care doctor that follows them over time for either a sick visit, chronic illnesses or preventative services. Um, as Sharita mentioned, if you're applying for disability, having a PCP is super important. And, people who are experiencing homelessness sometimes have let things, slide a little bit, but that doesn't mean they're not worried about them. Someone may be worried about their family history of breast cancer or a past abnormal pap smear if they're a woman, or their ongoing issues with asthma. And a primary care provider is the person who's going to help with those things. It won't happen in the emergency room, and it certainly won't happen inside the hospital. And then just a note to all of us, the federal government thinks it's really important. It's one of the Healthy People 2030 goals, and I've included a link to that site here. It essentially shows that people who get primary care services have better health overall, and that it's an important thing that we should all be striving for our neighbors who are homeless. Okay, next slide. So the other thing is most primary care clinics have social workers affiliated with them. I know mine does. I know Sharita, of course, is the best social worker in Durham. Other primary care clinics also have in-house social workers, can be super helpful to your clients. A PCP can refer for AIDS services, which is funded by Medicaid. Home health agencies, even if they're started initially by the hospital, require an ongoing primary care provider to sign off on orders. That's an absolute must. So folks need to have PCPs for that. Additionally, the ins and outs of insurance, PCPs tend to understand and can acquire cool stuff for clients that maybe other folks don't know about. And then if anybody needed placement in a group home or a nursing home setting, PCPs would be doing that type of paperwork. Next slide. So, there's a really cool, sometimes we say, well, how do we get primary care? And there's a really cool committee that's part of the Partnership for a Healthy Durham. It's been around for a long time. It's called the Access to Care Committee. And one of its, central roles is to try to figure out some of the stuff I'm talking about here. They're working on updating a primary care brochure. They're pending printing now. I've seen a sneak peek of it, and it looks great. They've identified a lot of locations available to uninsured and underinsured folks. And you may know some of the names already: Samaritan Clinic, Duke Outpatient Clinic, where I work, Lincoln. There's more, so stay tuned. That'll be coming out soon. Next slide. Yeah, so I don't need to talk through everything on this, but I wanted it a little bit for the record, which is that primary care providers serving the underserved in Durham have collaborated together and across systems for years. We've done some pretty cool stuff. I'm giving a shout out to community paramedics. They're on the slide, Harm Reduction Coalition, APS. We work hard with all of those organizations to serve folks who have needs. We pulled together a COVID homeless task force that worked across many people in this room and organizations in this room to figure out homeless isolation, something that's still going on right now. We actually have a client in it as we speak. We pulled together a team to start talking about, well, how do we help our folks living outside through this COVID situation? And that committee is still going on, currently chaired by Drew over at OTM. We started a disability work group. We were the first group in North Carolina to get authority to do in the field SSI applications. Before that, anybody would have to go to the local office, which is a real hassle to do their application. And our SOAR team was able to get the local group here to give us authority. And then that spreads statewide and actually currently nationally. That was our team here working across systems. We worked hard to help create a medical respite opportunity, which is now housed at PADC. And then at one point, we also wrote a grant to the state of North Carolina that included partners at Housing for New Hope and Urban Ministries to fund a nurse working with Housing for New Hope to help with their street outreach teams, bringing people into primary care. That's always been a little bit of a problem. And also to be placed at Urban Ministries to help people connect to primary care. And that was incredibly successful and very positive at that time. Next slide. So the how to pay for it part, you guys already know about this, but I just thought it was worth giving some info. A lot of the clinics will accept people without insurance. Duke Outpatient Clinic does. That's where I work. Samaritan, Lincoln, Healthcare for the Homeless does. And then, of course, there's the quote unquote charity care process, which is a financial assistance process at Duke and UNC. Medicaid expansion happened. It was late, but it's happened, and we really need to help all of our clients sign up. Unfortunately, this is an important point. Many clients are signed up with exchange plans, the Aetna exchange plans. We need to help them drop the exchange plans and sign up for Medicaid. This is really important. I don't think enough people know this. It's critical. And then Medicare is super complicated, but actually can be really helpful if it's used well. It's worth getting clients hooked up with our local Medicare specialists at Senior Pharmacist, and or talking to clinic social workers in their primary care sites about how best to use Medicare. Next slide. Yeah, so I have some questions for HSAC and the COC, and this might be something to think about over time, not anything that has to be answered right now, but is connection to primary care a metric that's currently tracked by COC members? Is that something that we are looking at as a system? Do shelter, rapid rehousing, and PSH partners keep documents and participant files identifying PCPs and mental health providers and the contact information? Are there training opportunities to augment staff knowledge of primary care? Something that, we could, sort of help team members know more about pathways to connect to care. Next slide. And if anybody wants to talk more about this, I think those of us working on access to primary care are pretty passionate. I probably could talk for all day about this topic. And I think we'd be happy to talk about ins and outs. We could have coffee, cookies, and collaboration. And there's my info. Thank you so much for allowing me to be here today.
I did fail to mention just one thing. So our site clinic is getting ready to change, and the announcement is not widespread yet. So I'm making the first public announcement of it. We will be transitioning to a daytime psychiatric clinic starting in July. We will have two 4-hour psychiatry persons available to patients in our clinic on Tuesday mornings, every Tuesday morning. In December, that will go to 3 people. So in December, we'll have 3 people for 4 hours on Tuesday mornings. There is a specific way folks need to get connected. They need to first establish care, see the PCP, and meet with me in order to get on that schedule. But it's very exciting to be able to do that because for some reason our folks are not connecting to our community-based resources like they should. And oftentimes, even when we bridge them and connect them, they still come back to us. So what we decided to do was to try to figure out how we could meet that need in a more tangible and immediate and responsible way because in our site clinic, as it stands now, the providers change every month. And so this would give a consistent provider available for somebody at least once a month, but potentially more than once a month. So I just want to let you guys know that that's coming down the pipe.
And I forgot to give a shout out in the collaboration section to Alliance and, the fabulous connection that we've had with them through something called the Health and Housing Pilot, which Josie can, give more info about, but which we've been really excited about that collaboration over about 6 years now. So thank you.
Thanks so much. Any questions, comments? Online? Yes.
So Sharita, to go back to the initial eligibility, you said people with leases are not eligible. Did I hear that right? So if you go into rapid rehousing okay.
Hold on.
So there's some fluidity to that, but it is on a case by case basis. That decision is made in collaboration with myself and the provider. A person can be a patient in our clinic 1 year past being stably housed. And stably housed is the key word. So if the housing is not stable, we can justify them continuing to receive their care in our clinic. And if we find that we transition them to another Lincoln clinic and they are just not going, and we're seeing concerns about their health, or they're showing up to the emergency room, then it's very likely that that person could be transitioned back to us if we're going to be the provider that can give them the continuity of care in the comfort level that is best for them.
And then just for the minutes and people that don't know, Julia, I mean, we know you as a super advocate, but what is your actual role? You've got a Duke address on there for the minutes.
I'm a nurse practitioner at Duke Outpatient Clinic, which is one of the safety net clinics. Yeah. And I'm also the clinical director of Durham Homeless Care Transitions, which is part of Project Access. Mhm. Thank you.
I was pointing at you. Okay. Any other questions? If you're online, you can also ask a question if you would like in the chat. Okay, great. Thank you so much for that presentation. That was really helpful. Thank you. Yeah, let's give them a round of applause. Great. All right, we're at the announcements section of our agenda. So any announcements that folks would like to share?
Good afternoon, everyone. I'm Jonathan Crooms with Durham County Veterans Services, and I wanted to share with HSAC an upcoming event. The annual Bull City Stand Down and Resource Fair for homeless and under-resourced veterans is going to be taking place on Saturday, April 27th from roughly 8 a.m. to 2 p.m. And if if your organizations are interested in volunteering or being vendors at the fair, they can sign up by going to the Joel Fund's website. The Joel Fund is one of the partners for the event, and they maintain a website. So you can go there if you just Google them and you can sign up. It is a great event every year, and wanted to go ahead and let folks know about it. We at Durham County Veterans Services will be there and hope you'll join as well. Oh, you know what? That would be helpful. It is at Greystone Church, which is 2601 Hillsborough Road here in Durham.
Thanks, Jonathan. Any other announcements? All right. Seeing none, we've reached the end of our agenda. Just remember to take a look at those reminders, upcoming meetings. If you're interested in joining one of our two committees, their meeting times are there. You could check it out. Our next meeting together will be online on March 27th on the fourth Wednesday. So with that, I will take a motion to adjourn, and remember to raise your hand for me. Thank you.
So moved, Madam Chair.
Thanks. That was Renee Vaughn. Do I have a second?
Second, Sharita.
Thank you, Sharita, with the second. We can, if you would like to be adjourned, you can say yay. Anyone against adjourning? No, okay. Thank you all so much for being with us today for this hybrid meeting and for our retreat this morning. Everyone have a great rest of your day.